Good day, students. I'm Dr. Lisa Kalimag. This lecture is divided into three parts. On this first video, I will be introducing you to evidence-based medicine. On the second and third video, we will learn how to do critical appraisal of literature regarding harm and prognosis, respectively. These are the objectives of the session. At the end of the session, the participants shall be able to perform the evidence-based medicine cycle, describe the steps in applying evidence-based medicine into one's clinical practice, create a searchable clinical question, appraise and use various types of research articles in solving clinical dilemmas relating to harm and prognosis. First, let us understand what is evidence-based medicine. These are three fundamental principles of EBM. The first is that in order to make the best clinical decisions for you and with your patient, you need to be aware of the best, most up-to-date available evidence. Second is that EBM provides guidance to decide whether evidence is more or less trustworthy. You will be able to evaluate the evidence and not just accept everything that is written in an article. The third principle is about personalizing decision-making. Yes, you base it on the evidence, but there is still a lot of leeway for you to consider the benefits and risks, burdens and costs, the patient's unique predicament, and their values and preferences. This is the EBM cycle, and this is how we use the medical literature to provide optimal patient care. You ask, acquire, appraise, apply, and act. And this is a patient-centered process. In asking, you formulate a clear clinical question based on a patient's clinical situation or dilemma. Then you acquire evidence by searching the literature for relevant clinical articles and choosing the most appropriate and up-to-date. Then when you appraise, that means you evaluate the evidence for its validity. Then you look at which of these findings are applicable to your patient. That is to apply. Finally, you act or you implement your findings to your patient. What are the benefits of EBM? You become self-reliant in updating yourself on the best evidence. Once you graduate from med school or residency or fellowship, there will be no more consultants or professors to teach you. Most of the time, you will have to search for answers yourself. Second is, of course, being up to date. But the purpose really of being up to date is to improve patient outcomes. You have to learn about new studies, new evidence of new drugs, new treatments that are more effective than the old treatments. Lastly, hopefully we decrease costs. Once we know which are the best and most cost-effective treatments, hopefully we discontinue the treatments that turns out don't really help our patients. I would like to drive home the point that values drive clinical decision-making. Values are the collection of goals, expectations, predispositions, and beliefs that individuals have for certain decisions and their potential outcomes. For example, in a case of pneumonia in a patient with chronic pain from terminal cancer who only wants palliative care, would you still admit the patient for IV antibiotics? What about in an 85-year-old woman with severe dementia who is mute and incontinent, who doesn't have a family and is in obvious discomfort? There's no right or wrong answer because we will be deciding based on values. But how about in a 30-year-old healthy mother of 2 children who develops pneumococcal pneumonia? Would you give antibiotics? We would almost universally give antibiotics to the third case, the healthy mother. But that doesn't mean that there is no value judgment in that decision. It's just that our values are sufficiently concordant and the benefits so overwhelm the risk of treatment that the underlying value judgment is not apparent. On average, clinicians have 5 to 8 questions about individual patients per daily shift and regularly use evidence-based medicine resources to answer them. However, finding useful evidence efficiently remains challenging due to the increasing volume of new literature. Approximately 2,000 new articles are indexed in PubMed every day. As many as 75 are randomized clinical trials, and 11 are systematic reviews, and only a few of them directly inform clinical practice. So how do we find the best evidence in this needle in a haystack kind of situation? We have to use the hierarchy of evidence and the hierarchy of EBM resources to search for answers. Let's look first at the hierarchy of evidence. For primary studies, the hierarchy of research designs depends on the type of research question. For therapy and harm, and at the top of the hierarchy is randomized trials, followed by observational studies like cohort and case control, followed by unsystematic observational studies. Questions of diagnosis, prognosis, and differential diagnosis would have different hierarchies of evidence. Now let's look at levels of processing. Primary studies are processed into systematic reviews, which are further processed into guidelines and decision analyses. But where should we look first for answers? You can see here the hierarchy of EBM resources. You look first at summaries and clinical practice guidelines. These are appraised summaries based on many primary studies and systematic reviews, and they usually have a wider scope than systematic reviews. And if those don't answer your clinical question, you look for pre-appraised research, which are synopsis and systematic reviews. If these are still not able to answer your clinical question, you would then look for non-pre-appraised research. These are your primary studies, which you would then appraise yourself. Most clinical questions would be answerable by summaries and guidelines. In very rare diseases or clinical scenarios or very novel treatments that don't have guidelines or systematic reviews yet, that's usually the time that you would search for primary studies. Here are some collections of clinical practice guidelines. You have the Compendium of DOH approved CPGs. The Philippine Academy of Family Physicians website also has compilations of various CPGs. There's also, for the international level, there's also the US National Guideline Clearinghouse and the UK National Institute for Health and Care Excellence. Most countries have their own compilations of CPGs. Summaries contain information per disease or symptom from clinical presentation, pathology, diagnostics, and treatment options. Here are some of the available online summaries. In the Filipino medical communities, UpToDate and Medscape are usually used. UpToDate is a paid subscription, but some institutions would give you access. Currently, DOH has a program that will give access to all government physicians. Now we move on to how to ask a proper clinical question. But first, let's differentiate between background and foreground questions. When you are a novice, for example, a medical student, your questions are usually background questions. For example, what is diabetes mellitus? Why does this patient have polyuria? What treatment options are available? Background questions are usually about pathophysiology, epidemiology, and well-accepted treatments. For background questions, it is best to look for answers in traditional medical textbooks. But as you become an expert, once you're done with training, you ask more and more foreground questions. These pertain to more specific clinical scenarios. Example, in patients with new onset type 2 diabetes mellitus, which clinical features or test results predict the development of diabetic complications? And in patients with type 2 diabetes mellitus requiring drug therapy, does starting with metformin treatment yield improved diabetes control and reduce long-term complications better than other initial treatments? It is for foreground questions that we need to go through the EBM cycle. Here are 5 types of foreground questions. Therapy determines the effect of interventions on patient-important outcomes. Outcomes may be improvement of symptoms or function, morbidity, mortality, and costs. Questions on harm are about ascertaining the effects of potentially harmful agents or risk factors, including therapies from the first type of question, on patient-important outcomes. Differential diagnosis questions in patients with a particular clinical presentation, they establish the frequency of underlying disorders. For example, if you have right lower quadrant abdominal pain in an elderly patient, how likely is it to be acute appendicitis versus something like diverticulitis? Diagnosis questions refer to establishing the power of a test, such as a blood test, an ECG, or imaging test, etc., to differentiate between those with and without a target condition or disease. Prognosis questions estimate a patient's future course. For example, for a certain disease, what would be the expected lifespan? This is a review on how to frame clinical questions using the PCOM format. Note that it can be either I or E in PCOM. P stands for patients or population, I for intervention or exposure. It can be diagnostic tests, foods, drugs, surgical procedures, time, or risk factors. C for comparator or control, and O for outcome. So consider this case. A 55-year-old woman presents with type 2 diabetes mellitus and hypertension. Her glycemic control is excellent with metformin, and she has no history of complications. To manage her hypertension, she takes a small daily dose of a thiazide diuretic. During a 6-month period, her blood pressure is near 155/88. Your initial question is, when treating hypertension, at what target blood pressure should we aim? How do we make that into a searchable clinical question? Per population, you could include patients with DM and hypertension without complications, since the patient has no history of complications. For intervention, you choose antihypertensive treatment with BP target of less than 130/80, and you compare it to a BP target of 140/90. The patient outcomes could be the development of complications of stroke, MI, cardiovascular death, or total mortality. For methodology, you would look for an RCT, cohort study, or case control study. This is assuming that you have tried to look in CPGs and systematic reviews and have not been able to answer your question. You would then use these as your search terms in journal databases such as PubMed. You should look for the most recent articles that match your clinical question. There are many EBM users guides based on the type of foreground clinical question. For today, we will be discussing the user's guides for harm and prognosis. Next year, you will be discussing therapeutics and diagnosis. You should know that there are also user's guides for prevention, differential diagnosis, health economic analysis, systematic review or meta-analysis, and clinical practice guidelines. However, these are beyond the scope of this course. These are the parts of the EBM user's guides for critical appraisal: relevance, validity, results, applicability, and conclusion. We will go through all of these one by one. So please go to the next video for the critical appraisal of literature on harm.